Hi there. Today's topic is management of patients with kidney disorders. Acute kidney failure. AKI is a rapid loss of renal function due to failure of renal circulation or damage to the tubules or glomeruli. The criteria for AKI is a 50% or greater increase in serum creatinine levels above the baseline. The normal serum creatinine is 0.7 to 1.4. This is usually reversible with spontaneous recovery in a few days to 2 weeks. The etiological categories or causes are three: pre-renal, intrinsic or intrarenal, and post-renal causes. Pre-renal causes, or in other words, causes related to outside the renal system, are the most common of the three and is the result of impaired blood flow leading to hypoperfusion of the kidneys. This can be due to volume depletion caused by burns, hemorrhage, GI losses, hypotension caused by sepsis, shock, diuretic therapy, circulatory collapse, or renal artery stenosis leading to decreased GFR. Once recognized and treated early, pre-renal related AKI are readily reversible. Intrarenal AKI. This is a result of actual parenchymal damage to the glomeruli or the kidney tubules. The causes for this type of AKI include prolonged pre-renal state, nephrotoxins like vancomycin and NSAIDs, contrast dyes, prolonged renal ischemia due to transfusion reaction, rhabdomyolysis, crush injuries, infections such as glomerulonephritis, and acute pyelonephritis. Postrenal AKI is caused by any condition that obstructs the flow of urine, such as renal calculi, strictures, BPH or benign prostatic hyperplasia, tumors, and blood clots. The classification of AKI is based on the Rifle classification. Risk, injury, failure. These are the three grades of severity of kidney failure, and loss and end-stage kidney failure are the two outcomes that will need some form of renal replacement therapy, at least temporarily. The Rifle classification takes into consideration the GFR, 25% reduction to 75% reduction or more, or the serum creatinine, increased 1.5 times the baseline to 3 times baseline, and the urinary output. There are 4 phases of AKI. The first is the initiation period. This phase begins with the initial insult to the kidney until the oliguric phase. During the oliguric phase, the urine output is less than 400 mL per 24 hours or 0.5 mL per kilogram per hour. The second phase is the oliguric phase. This is when the kidney is not able to excrete the excess electrolytes and other toxins. Increased levels of urea, creatinine, and other toxins is also referred to as azotemia. This results in increased BUN and creatinine, increased potassium, increased magnesium, decreased sodium, decreased pH, or in other words, acidosis, fluid overload, and high urine specific gravity, which is more than 1.020, and high urine osmolarity. The earliest sign of tubular damage is the inability to concentrate urine, which leads to a condition called isothenuria, or fixed specific gravity of urine at 1.010. Electrolyte imbalances also cause nausea and vomiting. The third phase is the diuretic phase, and this is marked by polyuria from diuresis, which signals that the glomerular filtration has started to recover. The diuresis can result in fluid volume deficit, monitor for dehydration during this period, hypokalemia, and hyponatremia, low specific gravity, less than 1.020, uremic symptoms may still be present. Sometimes patients may not experience the oliguric phase and may progress directly to the diuretic phase, during which the urine output may be as much as 10 liters per day. The last phase is a recovery phase, which indicates improvement of renal function, labs stabilize, and patient denies anorexia, nausea, vomiting, and regains lost body weight. Complete recovery may take up to 3 to 12 months. Assessment. Assess for the following: history of nephrotoxic drugs, alteration in urine output, edema, weight gain, and change in mental status. Assess the clinical manifestations of the 4 different phases: initiation, oliguric, diuretic, and recovery phase. Initiation phase has few manifestations. Oliguric phase has low urine output and fluid overload. So assess for signs and symptoms of tachypnea, hypertension, full and bounding pulse, jugular vein distension, peripheral edema, pulmonary edema, and weight gain. Body weight is a good indicator of fluid retention. Obtain body weight on the same scale at the same time with same amount of clothes every day. During the diuretic phase, assess for signs and symptoms of dehydration, which include decreased skin turgor, loss of body weight, dry mucous membranes, hypotension, tachycardia, and increased thirst. Older patients may not have thirst reflex and can potentiate dehydration. Recovery stage shows signs of improving urine output and renal function. Assess for signs and symptoms of electrolyte imbalance. Potassium has a critical safe range, that is 3.5 to 5, and hypo or hyperkalemia can affect the heart, and any imbalance must be corrected by medications or dietary modification. Bananas, orange juice, cantaloupe, spinach, and salt substitutes have high potassium content. Signs of hyperkalemia includes dizziness, muscle weakness, cardiac dysrhythmias, muscle cramps, diarrhea, and nausea. Assess for neurological signs and symptoms such as confusion, agitation, disorientation, seizures, and coma, which is common with hypo and hypernatremia. Assess for metabolic acidosis, including nausea, vomiting, lethargy, tachypnea, tachycardia, weakness, and confusion. Anemia, fatigue, dizziness, tachycardia, pallor, weakness, dyspnea, and shortness of breath. And azotemia, increased serum blood urea nitrogen and creatinine. Assess the diagnostic findings, that is lab findings, UA, urinalysis and urine culture findings, biopsy findings, etc. AKI nursing management. Monitor the intake and output accurately. Restrict fluids in the oliguric state. A fluid challenge may be ordered by the physician to differentiate the pre-renal AKI and intra and post-renal AKI. An IV bolus of 500 ml in a pre-renal AKI patient will result in an increase in urine output. There will be no change in urine output in intrarenal and post-renal and may result in increasing breathing difficulty or increased blood pressure. Therefore, further diagnostic tests like renal ultrasound, KUB, or CT scan may be performed to further diagnose the cause for the renal failure. Observe for oliguria followed by polyuria, daily weights, and observe for edema. Monitor complications of electrolyte imbalances, especially potassium. Encourage prescribed diet, restricted proteins, potassium and sodium, high carbohydrates if not diabetic. Provide pulmonary care and assist patient to turn, cough, and take deep breaths every 2 hours to prevent atelectasis and respiratory tract infections. Provide meticulous skin care. Prevent infections related to urinary catheters and IV lines. Provide psychological support to patient and family members. Avoid nephrotoxic drugs like aminoglycosides, vancomycin, tobramycin, gentamicin, NSAIDs, digoxin, and phenytoin, and ACE inhibitors. Avoid nephrotoxic drugs like administer diuretics and antihypertensives during the oliguric phase. Administer antacids or hydrogen receptor blockers to prevent gastric ulcers. Preventing AKI. Monitor kidney function prior to initiation and during administration of nephrotoxic drugs. Trough and peak levels. Trough levels are drawn before the scheduled dose, and peak is drawn soon after the scheduled dose is given. Closely monitor urine output every 2 to 4 hours in hospitalized patients. Monitor hourly in critically ill patients and notify physician promptly. Prevent and treat infections promptly to prevent sepsis and shock. Provide adequate hydration to patients at risk for dehydration, including before, during, and after surgery, contrast agents, and skeletal muscle injuries. Remove urinary catheters as soon as possible. Prevent ascending urinary tract infections. Prevent toxic drug effects by monitoring dosage, duration of use, and blood levels of all medications metabolized or excreted by the kidneys. Treat hypotension promptly. Patients above 60 years of age are more prone to AKI due to pre-renal causes such as dehydration due to a decreased thirst reflex and use of diuretics. Intrarenal causes due to nephrotoxic agents, use of medications and contrast agents for diagnostic purposes, and complications of major surgeries. Elderly patients' drugs must be closely monitored to prevent drug toxicity. The next topic is end-stage kidney disease or chronic kidney disease. Progressive, irreversible damage to the nephrons and glomeruli occurs in CKD. This causes accumulation of waste products in blood, resulting in uremic syndrome. 90% or more of nephrons gets destroyed and creatinine clearance decreases. Serum creatinine and BUN levels increase. Serum creatinine is a more sensitive indicator of renal function than BUN, since BUN is affected by protein intake, catabolism, etc. Chronic kidney disease occurs in stages with declining GFR. The fifth or the last stage is end-stage kidney disease, at which point regular dialysis or transplantation becomes necessary to sustain life. Most common causes of CKD are diabetes and hypertension. The other causes include glomerulonephritis, autoimmune disorders like SLE or systemic lupus erythematosus, polycystic kidneys, recurrent UTI, or urinary obstruction. Virtually every body system is affected. Cardiovascular disease is a predominant cause of death in patients with end-stage kidney disease. The stages of CKD. There are 5 stages of CKD based on the GFR. When patients progress to stage 4, discussions and preparation for lifelong dialysis and/or renal transplant is done with the nephrologist. Step 5 is when the kidneys cannot remove the body's waste or perform their regulatory functions, thus requiring renal replacement therapies to sustain life. Screening and early intervention are important since not all patients progress to stage 5. Treatment of hypertension, hyperglycemia, anemia, and detection of proteinuria will help slow disease progression and improve patient outcomes. Albumin or protein in urine can be detected using a dipstick at home. Diabetic patients must be taught to check for albumin in urine once a month for early identification and treatment of diabetic nephropathy with ACE inhibitors or with other antihypertensives. Microalbuminuria is less than 300 milligrams per 24 hours of albumin in urine, and macroalbuminuria is more than 300 milligrams of albumin in urine in 24 hours. Normally, there is no albumin or glucose in the urine.